Hello and welcome everyone. The program will start in about 30 minutes from now. And as you know that we always share a quiz after the webinar so that you can just fill it up and submit it in order to receive your certificate. So please feel free to use the chat box to share your questions and your comments. And also please share where are you from, where are you watching this program from. It will be so nice to hear you and to see your details. Please use the chat box feature generously to share your questions and your comments and if there's anything that you wish to know about. And I'm also so much happy, so thrilled to share that my book with Professor Luis Borba is going to hit the market quite soon, and you will be able to order it in a matter of just a few weeks now. So again, thank you so much, and please don't forget to um, visit my website newsneuro.xyz, and we've got more programs in line. And my next webinar is with Professor Martin Samis. Please join us on 5th February. And after that, there's a program with ILE. It will be registered with the ILE on Epilepsy Day. So please do join us on that one as well. I'm also collaborating with the GNC 2024, and I will be so happy to broadcast it for 2 days on 24th and 25th of February. Please find the details on my WhatsApp group. I will be sharing the link to my WhatsApp group so you can all join and have a look and stay updated. Please use the chat box and share where are you from and if you can listen to me clearly. Thank you very much again for joining in. We will be starting in about 11 minutes from now. Thank you. Hello, everyone, and welcome to the webinar. We will be starting in about 8 minutes from now. So please use the chat box to share where are you watching the webinar from, and we will be so happy to see you and to greet you. It's so nice to meet you all virtually. And please use the chat box to share your questions and your comments, and also do join the WhatsApp group of news to stay updated. And I've got a very good website for you to see all the projects that news have been working at, and the project that we have already finished. This webinar will be will have a quiz like always, and after submission of that quiz, which is non-graded, just keep in mind that all the quizzes that I give in the webinar are non-graded, and the quizzes are just mostly for your own practice and to assess your own knowledge and just for practice. So they are non-graded. You just need to submit the quiz at the end of the webinar just to get your certificate emailed directly to you. And as you can see, these certificates are personalized with your own name and your own ID, your own certificate ID, which is being allotted on each individual certificate. And also they contain the stamp of news. So again, thank you very much for joining us today. And please share where are you from, and also to join the WhatsApp group and join subscribe to my website as well. Thank you very, very much. We will be starting in about 6 minutes from now. Hi, sir. Thank you very much for joining us today. Hello, sir. Hello, sir. Can you hear me?
Yes, perfect, Maria. How are you?
Thank you so much, sir. I'm doing great. Thank you very, very much for joining us today. It's so good to see you here, talking to you on webinar.
Yes, it's my pleasure, and I promise to be not so long because I will show perhaps in all of a lot of years of experience, very interesting cases, and some things to say perhaps to the young people. I think it's better to say it in order to be not so bored about that. But
Uh,
I will try to show. Perhaps I will check to share the screen. We see what happened.
Thank you very much. Yes, sir. Please do take your time, as much time as you like, because many of us really, all of us rather, really wish to listen to you and to learn from your experience. It means so much to us that legendary neurosurgeons like you spare time from their busy schedules for neurosurgical education. And it really means a lot to us, sir. So please do take as much time as you like, because we will all be so happy to listen to your amazing lecture.
My pleasure. Can you see perhaps the
We can see,
screen?
we can
Okay,
see your slides.
I will try to put in the full screen, and we will
Exactly.
happen. Do you see the full screen? Yes. Okay.
Yes, sir.
Perfect.
Sir, you can also check your videos if you like, because we can only, I can just only see the, yeah, exactly. So if you wish to play it and have a test of of the player.
Yes. I will try to check things, and we'll see what happens with that. Take the first slide, for example. I will. It's okay.
Exactly, sir. It's perfect, sir.
Perfect. Okay. Okay. I will come back, and then we'll
Sure.
stay in touch.
Sure, sir. I will just give a very short, brief introduction for you because, no, you don't need any introduction because all of us know you
No,
well.
it's
But
not, that is not important, Maria. The most important is perhaps to work a lot of several years to learn about that each other, and that's all.
yeah,
The
thank you.
introduction and a lot of titles that you have, fellow, and a lot of things. Sometimes it's important, but if we wait perhaps much more year, we'll see what this the very important thing to take in mind about that. Okay.
Yes, and it's your very humble self to say this, but obviously there are so many accolades that I don't think that we can actually do justice to tell how much you have contributed in the field of neuroendoscopy and neurosurgery on the whole. So basically, whatever we say won't be enough. It's just a little bit of formality or a little bit of courtesy that we really wish to express, but obviously your dedication, your contribution are what really matter, and obviously your lecture it's what really matter. And while COVID-19 was a very very bad experience for all of us, especially people of my age, because we thought that it's the end, but it's because of neurosurgeons like you that we are still learning, and we kept on learning even during those times when it was so much challenging. So I think that there's
For
nothing
sure.
more than
That
that.
is that is true. I think neurosurgery, you can learn neurosurgery perhaps no more than 30 years. You need a lot of time to learn a lot of things, and perhaps a lot of things you cannot learn in all of your life. That is the matter of the thing, and it's not so easy. But doesn't matter. The most important thing is to share the experience, to be humble, because we have a lot of pathologies, very difficult to solve, and then up to now it's very difficult to solve some tumors, hydrocephalus, a lot of things. But we try.
Exactly. So and it means a lot to us to learn from you because it is a privilege. It's like a dream come true. It's so surreal. Exactly what I can say because obviously learning directly from masters like you is something really big, especially from for trainees and for young neurosurgeons from countries where neurosurgery is still developing, including Pakistan, where many of the things are still in development. So it means so much. Like personally, I can see I've learned more and more each day directly. I have this huge privilege that I can just listen to your lectures, see your cases, see the world through your experience, and obviously this really counts. It's. I don't think I have words to express how much it really means.
Thank you so much. Thank you so much. Well, you tell me when we can start. Perhaps wait a little bit more, and you tell me. I am ready to start
Sure,
with
sir.
the
I
things.
think people will keep on joining us, and there are so many people
Yes.
who are watching us live on YouTube as well as on neurosurgical.tv. So there will be there are separate attendees over there, and there are a few over here. So again, and sir, obviously, I really want to appreciate your diverse personality because you are a wonderful, a very gifted musician, and it's so amazing, and it really means how the dexterity that you have as a surgeon and as a musician, and it's a high level of cerebral intelligence, I can say, sir. So I really appreciate it.
Thank you so much. Thank you. Thank you. We'll see. We'll see. Perhaps in the future, during my presidency, 2 years, we must stay in touch with another colleagues from near to India, Pakistan, and a lot of countries in this area, in order to organize courses or stay in touch about that. I try to promote your efforts about the organizations and a lot of things. So you count me on every time if you need it.
Thank you so
Only
much.
write. Yes, only write to me and write to the Professor Suresh, that is the coordinator of the educational committee of the International Federation, and we'll stay in touch about all of the things.
Thank you so much, sir. It means so much, and I think that I will certainly contact you because it will be a huge privilege and an amazing opportunity, learning opportunity for people in our region. It means so much, and it's a huge honor. So thank you very, very much. I don't have words, sir. I'm so at a
Pleasure.
loss for words for this. Thank you very, very much, sir. Again, sir, I will just say a couple of lines. If you, sir, if you wish to start the lecture, we can proceed with it. I think more and more of the attendees are constantly joining us.
No problem. If you like, I can start now, or perhaps in 2 minutes. So you tell me. I am ready.
So thank you very much. I know you have a very busy schedule, so I think that we won't take much of your time in this, waiting. So I will just give a brief introduction, and then the floor will be all yours, sir. Again, very, very much. Thank you very, very much.
Okay.
Just a brief introduction, just a few lines that I wish to share with the audience about you, sir. Professor Alvaro Cordoba is the current president of the International Federation of Neuroendoscopy, and he's been selected for the second time for the presidency of IFNE. He's the chief neurosurgeon at the British Hospital in Montevideo, and moreover, he's a music prodigy and a gifted musician, making us realize that neurosurgery is artistry, and it takes a sharp, diverse mind to translate it to the competency level of an individual neurosurgeon. Having noticed that Spotify identified about 700 of its users are surgeons who use music during operation, and they also took a research to another level, and they shared that most of those neurosurgeons who listen to music during surgery have more focus on their procedures, and they complete their procedures at a shorter length of time and give much better results than those who do not listen to music. So this is very interesting, and I think that makes us have a very good connection of music and neurosurgery. And it's yes, exactly. So, and so there's also intra and pre-operative music intervention I have heard of, especially for pain control and spinal surgery. They have shared that intra, like pre-operative music and after operation, those who are give this, tendency to listen to more music tend to recover in much better way. So it was a very interesting study I came across a few days ago. And that really correlates better. So again, thank
Sure.
you very much, sir, for joining the webinar, and the floor is all yours now. Please take your time, and we will all be all ears for you. Thank you so much.
Thank you very much. This is very interesting subject because the music and neurosurgery in the long time is perhaps another subject for another lecture. Because actually you have a lot of information about that, very interesting, how to develop brain connections, neuroplasticity in the bifrontal temporal lobes in the inner surface. And it's very, very interesting to see what happened with sometimes the frequency of the sounds in the big famous composers like Beethoven, Bach, Mozart. That is very interesting to see. But perhaps in another I will explain to you about this very interesting subject. Well, dear friends, thank you so much for the invitation, for your words. And I show you not so long, I try to be not so long and not too bored, because we started the endoscopy a long time ago in 2002. And the reason was, I remember very well the first patient that they have. This a very complicated patient after a subarachnoidal hemorrhage and a very huge ventriculitis. So it's very difficult to solve. I remember the very huge ventriculitis, and we started in 2002 with brain lavage. Actually, it's very famous. We in 2002, perhaps a little bit less, but we have a very nice results with this patient. So we encourage to continue perform the endoscopy in hydrocephalus and other things.
Excuse
So
me, sir, the slides. Yes, thank you very much. Yes, thank you so much. There was.
this is part of our activity in the past, actually in the International Federation, but it is not important. Perhaps when I was young, it was very important because the fame or the exitus or sometimes a lot of things that I persuade every year, all of your life are very important. But actually, you consider you have a much more important things to take in mind in your career. So this is only the result of a lot of years. You try to learn endoscopy not in 8 years, in 10 years, more than 30, 35 years in practice. So you will see a lot of different kind of cases, very difficult cases. You are always fighting against the death, and a lot of things that actually is possible to think. Perhaps 30 years ago, a little bit less, but we must to take in mind this kind of subject. And the disclosure is I never have a support of the companies, never, because I live in a small country, actually 3 million and a little bit more. And it's difficult that a company support activities in very small field in medicine. It's not like gynecology, urology, anti-surgeons, and a lot of things. Neurosurgery is a very small field, and in endoscopy also. So I start with buying with myself, with my own money, my own pocket, a lot of things that I need to do this kind of technique in my country, and I never try to claim money and other patients about that. The reason is was not possible to pay by the patient, and this is the possibility to refuse to develop the technique. So I have never support of the company. So I am very criticism about the technique also, and for me is very important. Actually, I am the International Federation of Presidents. I know what we need the companies for sure, but I try to separate the things. I try to separate economy, business, and science. So it's very important in neurosurgery. Another thing is to think what happened in the past. This is a skull that I discovered in Jordan, in the National Museum of Jordan. This is from the Paleolithic age. And you see here to the frontal suture, the coronal suture, some points like Kocher point. And this was very interesting. That is not, I think, or I thought when I saw this kind of skull in the museum, that the person, the man that they did these burr holes, thought perhaps near something like, for example, Kocher or another neurosurgeon thought about the best way to approach some things perhaps is near to the frontal and coronal suture. It's something like that we are normally used in the approach, and it's not really casual, if you see, because I saw a lot of trephinations in different cultures, completely abnormal, perhaps in the frontal, in the middle, but this is really amazing. If you see at the level of the coronal suture and a little bit at the front, that's the Kocher point. That is very interesting to see, because in the past, we don't know what happened, really. So we must to take in mind about all of the things of the history. That is our report, a lot of cases, more than 3,500 up to now. We collaborate with a lot of clinical. I learned this in the Medizinische Universität Wien in Vienna. We collaborate also with St. Louis University, with the Dundee Society, and actually with the International Federation and the Latin American Study Group. So that takes normally a lot of years, at least 20 years of experience doing these kind of things. When I was a student, I started here, you see the date, 1982. And I started the second year of medicine trying to dissect the brain. And this is the laboratory. When I was young, I am in the middle, sitting in the middle with a lot of hair. And we see all of the professors that they teach to me a lot of things about how to dissect in the Klinger method, the fiber tracks, white matter, and the combination with the Milan technique in 1982. Actually, it's very, very famous, this procedure with tractography, with awake surgery, a lot of different areas to trying to check the function of the areas, like Professor Dufault, a lot of things. But the concept is very ancient. And I remember very well this period of my life because I learned anatomy. I am a neuroanatomist also, and was very important to learn from the ancient authors of anatomy. At this time, Professor Roton didn't start to microsurgical anatomy, but a lot of classical authors describe a lot of things in neuroanatomy, like the French school, like the German school of anatomy, the Austrian school of anatomy, in a very nice manner. So different age was when the microsurgical anatomy appears, and it's very important to take in mind that in the past, the history of anatomy is very important. This was the first procedure during this patient during a very severe ventriculitis after a subarachnoidal hemorrhage. And you see the first endoscope that we use was a pediatric ureteroscope. But if you see the model, it's something like the model GAP1. So it's a little bit modified by the model GAP1 by the same company. So we have the heritage of the urology with the anti-surgeon, like the microscope in neurosurgery. We must to think about that because we have the heritage of a lot of disciplines around of neurosurgery that we use in the neurosurgical manner. So was my first presentation in the Naples Congress. Was the International Study Group of Neuroendoscopy, and it's very interesting to see because it was one of the first papers in the brain lavage, ventricular lavage, that actually is in the top of the wave. And really, I have a lot of papers in pediatric, a lot of very interesting results. And remember very well, mainly in childs, no? But remember very well this patient because the patient had a very nice evolution, a very nice outcome with this lavage. Then we continue with a very enthusiastic manner, developing a little bit things. For example, a small cannula that you see in the left, through the endoscope, this model, the intracranial pressure monitoring with different kind of monitors, like in the intensive care unit during the procedure, to see what happened. I remember a lot of friends in Spain. Professor Ferrer, for example, started a very nice during the 2005, 2006. A lot of papers about the monitoring during the procedure. It was very interesting as he saw a lot of different changes if you cross a level of more than 25 millimeters of mercury in this limit. If you see a lot of problems, a lot of complications, late awake, some disturbances in the hypothalamus, and a lot of SIGs. Very interesting. The other thing that we thought is try to introduce not so wide, not so big endoscope in the brain. So we use this 0.9 millimeters endoscope with a very nice image that you see to put and to go in the very small ventricles, or for example, to cross in a very small foramen of Monro, of Magendie-Monro, for example. So we try to develop things very slowly, but a very enthusiastic technique, and try to learn for all of the masters over the world, mainly in Europe, because I remember very well a very ancient professors like Professor Bauer, Professor Helvig, for example, also Professor Gab, and a lot of professors, Gotten, who is from the Netherlands, and I learned a lot about this technique. And we introduced also a 3-chip camera. A lot of these materials I bought by myself. So I earned much more money, and I expend normally a lot of money, like the last generations, much more than car, for example. But doesn't matter. I try to introduce in my country these things, and then we have the results in the future. Then we try to use a very good friend of mine in Brazil gave to me a flexible endoscope. It was a very interesting experience, but completely different. In this model, as if here 2005 were very different, very not so nice images. Actually, it's very nice. It's possible to use, but they improve a lot the quality of the images if you compare with the rigid endoscopes. So it's very important to take in mind that. Also the echography. Remember very well, one of the professors of Germany developed a small system through the endoscope in order to make the ultrasonography guidance endoscopy, neuroendoscopy. So it's very interesting to do, but actually it's completely not used, not so frequently. But if you have a common ultrasonography machine, it's possible to put in parallel in the fontanelle, anterior fontanelle in the childs. It's possible to combine the technique when you introduce inside of the endoscope in the ventricle. It's possible to check with the ultrasonography machine with echography. Is very interesting to see what happens. You have in this moment you have a very important really brain navigation, really neuro navigation in real time. You see here, this is another example. We try to introduce several things in order to see what happens when you perform an endoscopic cerebroventriculostomy or aqueductoplasty, for example. And then suddenly this we must to refenestrate in order at 1, 2, or 3, 6 months try to close this ostoma. We use a coronary stent like the neuroform in this period. You compare with the endovascular procedures in neurosurgery, and we put in the two stents, one in the ostoma, in the ostomia of the near to the endoscopic cerebroventriculostomy, and the other in the Sylvian aqueduct. It is possible to see. It was described by Professor Grotten, who is a long time in your book, and it's very interesting to see like a very interesting procedure, a very novel procedure. Yeah, here you see a lot of different kind of images that normally you see when you introduce the endoscope. It's a very huge surprise because the anatomy is completely different, and you must to be very trained about that. Not always you have the similar foramen of Monroe, the septum, you have agenesia, you have aplasia, dysplasia, and it's possible normally to see a lot of scar near to the floor of the third ventricle. So the risk is very high. And if you see here, it's possible to check in real time with the ecography, intraoperative ecography. You see the flow with the blue lights, the blue color you see here in the floor of the third ventricle going to the prepontine system. So progressively we try to introduce things in several years in order to do much more complete the technique, try to improve the results. Here you see a lot of things completely different. For example, for the same approach in the precoronal, you see all of the very huge foramen of Monroe, and it's possible to see the posterior part of the third ventricle. It's not necessary to go with a very much frontal bar hole, for example. And it's possible to do the aqueductoplasty in a child. You see here with the necessary of modify the approach, because the anatomy that you discover is completely distorted. So sometimes you don't need to perhaps to do a different approach, different bar holes that is normal in a normal anatomy. So we must to be prepared about to discover this result. You see here, I put the stent in the lower part of the left slide. Stent, a common stent normally, or perhaps part of the ventricular catheter, like after the aqueductoplasty, the stenting of the aqueduct. Remember the first very enthusiastic results from Professor Schroeder, then they check in a lot of years after that they not so enthusiastic about the procedure. That is another thing to take in mind. When you start, all of our colleagues start with a procedure, then the years check the results, and then you discover you are in the wrong way, or really you are in the way that is possible to be enthusiastic and to continue the technique. For example, you see here, in the same approach, we discover this kind of anatomy. You must be prepared about that. For example, a very huge foramen of Monroe, interthalamic commissure posterior part of the third ventricle. And for example, in another case, you see a lot of distorted anatomy that is possible to recognize. A not so huge foramen of Monroe is difficult to pass. It's possible to perform perhaps from the middle of the fornix, the interpharyngeal approach for the ATV, and discover what happened with the distorted anatomy. You see part of the leaf of the septum covering the septal vein and the thalamo-sphenic vein, for example, and the fissure angle. You see there. So it's very difficult if you are not trained in this kind of things to discover and to be oriented in this kind of procedure. So you need a lot of years to practice and to discover that. This is a part of, for example, another example of cyst fenestration that you use normally. It's possible to use in the ecography during the fenestration, and you discover a lot of things. For example, it's very difficult sometimes to go through the cyst, and you have a very wide wall in order to fenestrate and to reach the ventricle. And sometimes you need to leave a catheter, or sometimes it's very important to make a very huge fenestration in order to communicate, and sometimes to check with a neuroradiologist with contrast, for example, as you have the huge communication or not, in order to be successful or not the procedure. You see here, for example, when you use in the subarachnoidal space the endoscopy, for example, one of the princeps elements is the cerebropontine angular lesions. For example, you see here and cyst, and another cyst of this area. You check the ICA, you check the several 7 and 8 cranial nerves, and the lower nerves also. That is very, very nice view, and it's very interesting to check and to use in the subarachnoidal space in order to combine the resection of the tumor. But it's possible to use in another place, also near to the prepontine system. But I think in this part is perhaps is the most important, is the princeps element, to use the endoscope to make the fenestration by, for example, by bar hole in the cranial, in the occipital bone, and it's possible to reach the lesion. Or if you perhaps you need to check after a small craniotomy, conventional craniotomy by microsurgical approach of this lesion, it's possible to check all of the things. So this is another possibility that we use progressively in the our experience. But also we extend to the spine. You see here very nice images. For example, in the syringomyelic cavity, you see here it's a small catheter. You see also the spine with the medulla oblongata, the upper part of the medulla, near to the cervical approach. You see here it's possible also to fenestrate a subarachnoidal cyst, spinal subarachnoidal cyst, and also it's possible to check with echography. So progressively, it's possible to use a lot of possibility in order to improve the results of the endoscopy. That is also one lesion of the much more famous, the colloid cyst. We have a lot of different kinds of approaches. Actually, we have a very huge, a lot of papers comparing the results in a small approach with a small craniotomy. Sometimes it's not possible to remove because it's it depends of the consistency of the capsule, of the content of the cyst. So it's possible also to replace the procedure. We think about that because endoscopy is possible to solve the problem, but sometimes not. And we must be prepared to make the conversion of the procedure if you need. And normally the colloid cyst was much more famous, perhaps, during a long time ago. In this approach is very interesting because when I saw a lot of different kind of tumors, also with recidue, was the endoscopy perhaps helps in order to put some guides of brachytherapy, for example, inside of the tumor. This is a pineoblastoma, it's a huge residue that we put inside of the tumor 4 guides of iridium, and was after 1 month and a half. If you see below, you have a lot of necrosis. So with neuroendoscopy, try to aspirate in a very safe manner with a very nice result. And the other was a recidue of the ependymoma. You see here, it is possible perhaps to solve during the resection no more than 2.5 centimeters in intraventricular procedure. So you see here, this is a very huge residue of ependymoma that we approach, and we approach with the endoscopic approach, and we put several guides for brachytherapy, and in the below you see the results. Very important. You see here is a very thin guide inside of the endoscope that is possible sometimes to have nice results with iridium without a second or a third approach, very huge with a lot of high possibility of complications. So I think thinking about the procedure and thinking that this kind of procedure exists, that is necessary to take in mind, perhaps to give the patients a lot of possibilities. That is part of our normally our lectures in Naples. I think Naples is one of the best courses that I encourage all of you to come every year during January and February with Professor Cinali. Is a pioneer, a very big master, an excellent person also. Actually, he has completely sold out for our course next week. And we are permanently every year in this course. Normally, the endoscopy-assisted microsurgery in brain tumors is our lecture, but we have a lot of things. You have here the use of the endoscopy in the subarachnoidal space with a lot of very nice in anatomy mainly, and then when it's possible to do, because it's not so easy, and it's sometimes dangerous. Sometimes during the procedure, we have a lot of lesions with the light, the temperature of the light of the endoscope near to the cranial nerves. You must irrigate permanently. in order to not to hit so much. And sometimes it's possible to develop bradycardia near to the lower cranial nerves. So it's not so easy to make a travel near to the subarachnoid space. Only a little bit, only to see, to make the procedure, and then to give up the procedure and coming back. So you have a lot of different kind of images. For example, this is a very huge tip basilar aneurysm that is normally protruded near to the third ventricle. You see there. You see the image with endoscope in the subarachnoid space and in the intraventricular third ventricular image. And in the lower part at the right is another image for a very small child with part of a very not so clear tumor of the pituitary tumor, pituitary area. That normally was only was a dysplasia, was not a tumor. That is possible to approach through a very huge arachnoidal cyst, intraventricular cyst. So it was possible to fenestrate, and you see from above both foramen of Monro, both fornix, and the floor with this dysplasia protruded into the third ventricle. So we have a different kind of images that we must learn. Another thing is the endonasal approach, that is very famous now, only with the classical endonasal and expanded with a lot of approaches, also the orbital approach, and it's very important to take in account. You see here, it's very interesting. In the upper part, a lot of different kind of endoscopes with different angles, and in the lower part, the very thin endoscope that we use to approach from different parts of the approach near to the posterior fossa, for example. That is very classic. Also, we try to do this kind of procedure using the fiber tracking, and that is very interesting to see, because if you see this part, you see this approach. It's the same that we learned a long time ago when I was a student. I try to dissect all of the fibers. We learn a lot, but actually you have the possibility with the DTI and a lot of very interesting things. So it's very important to learn when we are a student some anatomy things that is possible to dissect. You see here, and if you compare, actually, it's incredible that it's possible to the high resolution data E, for example, that is possible to see what happened. So the basis is the classical anatomy, and then the type 2 combination of the normally with neuroradiological images and MRI and so on. Very nice course with Professor Boltberger in 2015, and actually also this is tractography workshop. It is possible to do with a brain navigator, and also actually is very important. But it's always the same. We must to learn with the classical authors. For example, Professor Raymond Biozan was one of the main authors that developed in the book Neurographia Universalis a lot of things about the fibers, and try to do that with fixation by boiling in water and oil. So he dissect a lot of things during 1691, 41, and 1716. So it's very interesting that a lot of authors, for example, Vigdacier, you see here, he developed the Traité d'Anatomie and Physiologie with alcohol fixation. That is very interesting. And they developed the notion of commissural and associated pathways. You see here the images of Professor Vigdacier, also Professor Christian Reil, and was created the term psychiatry, for example, with several publications. They described the corona radiata, tapetum, optic radiation, insula, and so on. That was the Christian Reil dissections you see here. Also, Franz Joseph Gall with the book of Anatomy and Physiologie du Cerveau. Here also, Spurse and Gall. You see here The term of phrenology was developed by Professor Gall. Actually, it's very famous. We have a lot of things near to develop and use it, but very ancient civilizations, like in China, for example. You see here the section of Professor Spurheim, very interesting. Also Professor Mayo, you see here, a lot of fiber dissections, very nice. For Bill also, Gratulé. Professor Theodor Meinert was very important because established association systems, commissural systems, and projection systems. So it's very important to take in mind and not to forget these authors. And if you have the books, it's very important to see. Also Paul Flechig, for example, also Desjardins, with anatomy of the central nerve. You see here, the development, the rows, very important. Also, these connections syndromes, actually in animals, are actually in a lot of studies about the functional behavior of the brain. But Joseph Klinger was perhaps the most famous because they developed the freeze process about how to dissect and to combine the formal fixation or formal fixation and they proceed with the Gefiel process in German. You see here that is very famous. All know this concept. We tried the 2012 to introduce for the first time in our country the brain navigation, and actually we try to do in the axiom navigation in electromagnetic manner, because I think it's very important to introduce inside of the endoscope. I learned about that in Vienna with Professor Bolsberger. He had a very nice study about the currency and the efficacy of a lot of safety about the procedure. Here it's possible to put inside of the aspirator, inside of the endoscope, and normally it's possible to check in the axiom manner where is the endoscope, where we are trying to work about this kind of procedure and how to reach the lesion. You have the results here, the stylet, the pointer, the usual pointer. It's very interesting. If you see the paper, I recommend to try to read, because the results included intracranial, microsurgical, transsphenoidal, endoscopic, ventriculostomy, cyst, and so on. So it's very interesting to see. We'll learn about that. One of the other things is to add the contact optics. That actually is a very important procedure. This is confocal endoscopy. It's an optic that we learn about the urologist and the gynecologist. And it's possible to use like a common optic, but it's possible to put in the surface. You see here, the surface of the tumor. It's possible to check in the microsurgical, the microscopical range. So you see all of the borders of the resection. You see all of the cells with the pathologies beside you when you are operating, like intraoperative pathology. It's possible to use also a lot of reactive, blue methionine, hematoxylin, eosin, and fluorescence. And that is the first generation of contact confocal optic for Professor D'Andrea. And we try to combine all of the approaches, classical approaches, and to check the borders in order to make the maximal or supramaximal resection. Also, we combine with deep brain stimulation and a lot of things that is possible to increase the safe. For example, this kind very huge tumor, low-grade tumor, with the use of another tumor with the tractography. And it's possible to check what happened near the reconstruction in 3D. It's possible to check the area and try to plan where is the border of the tumor and to check with the confocal endoscopy. And also it's possible to use like a common endoscope, but also with like a microscope. You see here the blue, a lot of high-grade glioma, a lot of edema and fiber and white fiber tracts that is possible to conserve. Here is part of the multimodality approach also, if you plan with navigation and confocal endoscopy. Again, here with tractography near to the tumor and near around of the tumor and near to the brain stem. with corticospinal tracts. This is the image that you can obtain like a microscope. Obviously, if you are not so trained, you need a pathologist besides you, but sometimes it's possible to do alone because we have a lot of training. It's possible to recognize where are the border of the tumor, and it's possible to resect with in the concept of maximal, supramaximal approach. You see here, that is possible also to do. And here is, for example, a pontine marine glioma that was possible to approach like a lateral approach, retrosigmoidal. And in order to check, to use, for example, you see here tractography, but here you see the approach that is possible to do. This video that I think is not functional, but you see here the use of the bed of the tumor near to the prepoint and cistern, near to the prepoint and area, and it's possible to use this endoscope, confocal endoscope, like a common, normally a common endoscope. You see here the post-op. Also, it's possible to use in transphenodal approach. So it's very important sometimes to check where is the tumor area, where is the pituitary stalk, for example. That is possible to put through the nose, you see here, and it's possible to compare the approach, the classical approach. It's possible to see around if you compare with the classical histological slices. So it's very interesting to see and to use in a normally in apoplexy, for example, when you evacuate all of the hematoma inside of the pituitary gland, and then to check what is tumor, what is infarct, and what is pituitary stalk. Sometimes it's easy, but sometimes it's not so easy. This is one of the probes for spectroscopy that is very, very expensive, but we have not. And normally, in the advantages of this kind of endoscopes with both possibilities is the multimodality approach to brain tumors, the use of endoscope images in a micro range of resolution, the safety of the resection of the tumor, you are checking every time, and normally it's possible to use the reactives without the complications at the brain surface. The disadvantages there, you need a learning curve. The coordination of the use of 3 micro ranges increases. It's very difficult sometimes. Sometimes it's, you obtain blurry images, poor enhance of cells, and a little bit more spend time, but no more. So I think actually we have the last generation with laser and so on. They are very expensive, that they are trying to prove in several countries, and it's very interesting to do. But I never forgot our starts, because when I was a student, we present these kind of things, and with kind of dissections in Argentina, in Mar del Plata, you see our dissections. So we learn a lot about that. And actually, if you compare with that, we need this knowledge a long time ago to try to operate with safety for the patient. You see here the surface, you see here the use of fluorescein, for example, and it's possible in this surface the use of the confocal endoscopy. Also, it's possible to use in the spine. You see here the spine glioma with fluorescence, with a very huge border with a lot of colors, and it's possible to resect in a very safe manner, and it's possible also to check the use the endoscope, and it's possible also to use it to check with confocal endoscopy. Remember a lot of several courses that we did here in Uruguay. You see here Professor Forsberg and Professor Chinali, with a lot of Brazilian and Argentinian, and a lot of persons, a lot of colleagues that are learning anatomy department a long time ago. And this part we did a lot of courses, all here in Uruguay and around Latin America and worldwide. And also a lot of perhaps prizes or something like that, because this novel approach, like brachytherapy, for example, through the endoscope, was recognized with a very nice paper a long time ago in the Society of Radiotherapy here in Latin America and Argentina. Also with the concept of minimal invasive access for the skull base, that was developed by Professor Parnesky, a very huge school in Germany, that they learn a lot of actual very famous masters in neuroendoscopy.
So you see here it's possible to reach from the front, from below, from behind, with a very small approach. Actually, it's not only through a bar hole, it's a very perhaps 1-2 centimeters, and it's possible also to use this kind of procedure. We do this kind of approaches much more standard, mainly from the frontal basal and transnasal approach. We do this kind of procedure with the NT surgeon team. That is very important to try to work in team, because the NT surgeons have much more manage of the nasoseptal time, nasoseptal flux, for example, and we need it every time. Also, I show the images from behind, from the keyhole retrosigmoidal craniotomy. Is possible to reach from the cerebellopontine angle, the microvascular decompression, for example, cyst, not so big neurinomas, and so on. That is very important to see here. That is anatomy repairs of anatomy landmarks. It's possible to recognize. And also we did the lateral position, or perhaps in park-bench position. Then we try to develop the tubular approaches from the tumor. Normally, they develop this kind of instruments by ourselves. And then we'll learn a lot of things about another professor with a mini craniotomy, for example. We put with a mini craniotomy, mini dural approach, an opening, and we put the expanded tubular retractors. So it's another part that we try to introduce in the last 2 years. And for example, with brain retraction injuries, 5 and 10%, with tubular retractors less than 5%. But it's not so easy, perhaps, to learn when you are a little bit ancient neurosurgeon, that you learn a lot about microsurgical approaches, classical. But if you compare, for example, with a spatula, you have this kind of lesions, and with the tubular retractor, you have this kind of lesion. So I think it's very important to learn in the field of the neuroendoscopy, minimal invasive approach and neuroendoscopy, these kind of approaches, in order to combine the use of endoscopy. You see here, with the use of endoscopy near to the bipolar, scissors, aspirators, and a lot of things. That is also very important that the young people try to practice. Endoport is one of the marks or trademarks that doesn't matter, but normally they said that the trauma is minimal brain trauma, distribution of the direction of the retraction, and so on. That is very important to compare. And I think it's sometimes in not so huge tumor, in order not to move so much the endoscope, it's very important to do these kind of things. This is a mini craniotomy approach, and then to aspirate inside, also for the hematoma. And actually, it's possible to see a lot of papers that is possible to use, like in a multimodality approach. The use of an endoscope also in the micro range is possible with the confocal endoscopy, the safer sections, and it's possible also in the surface the use of reactives. This is another thing, very important. We combine a lot of ventricular and skull-based courses in St. Louis University with Professor Samer El-Baba, Professor Salem Abdulrauf. A long time ago, actually, it's a little bit suspended, but I think it will be return. The next, we restart with the activities in this year. But I recommend, because the laboratory is very huge, normally the trainees are very, very enthusiastic, and the trainers are very, very nice from over the world, from the United States. And they learn a lot about combined ventricular and skull-based approaches. And we present a very, in the case of vascular approach, using an endoscope, the case of this with a 57, sorry, real South woman with a long-term hydrocephalus with headaches and dysarthria. A long time ago, they did this kind of procedure in order to check what happened. We have no CT, because we was in 1972. It's only scintigraphy, and you see only hydrocephalus. It's very interesting. You see here the neurosurgeons operate with kind of images without MRI, perhaps with myelography, perhaps with pneumoencephalography, and this centellography, cystanocentellography. That is very incredible. That the procedure was not very clear what they did, shuntatam, punction, nothing. And then in 2016, we did a MRI and discovered a cavernous angioma near to the brainstem with a huge hydrocephalus. We decided to approach perhaps in this part you see here through the third ventricle, through the huge hydrocephalus, and in order to try to do the third ventriculostomy, you see, and then it's possible also to propose to the relatives the possibilities to approach. The relatives refused to be treated by an open approach, perhaps ATV alone, or try to ATV to explore near to the aqueduct in order to discover. And they discovered through the aqueduct, you see here, a very uncommon type of cavernous angioma near to the brainstem, a cystic, predominant cystic angioma that was possible to remove through the aqueduct and to resect the capsule. And this was very interesting to see. And really, you see here the post-op, actually with completely reduced of the lesion, the collapse. And this is one of the type of this is the patient, and this is the typical cystic form, which is predisposed to bleeding and grow like a subdural chronic hematoma. So it's necessary try to approach and to evacuate as is possible to resect or not the capsule. It's quite similar to the subdural hematoma, and it's very typical in the female. So it's not one kind of difficult resection of cavernous angioma, but much more firm, difficult, but much more bleeding and so on. So this is the reason that was possible to approach through the very huge Sylvian aqueduct and was possible to resect. You see here is the malcaverin is a genetic problem, and are in the basis of this kind of cavernous angioma lesions, and it's encountered in more than 40% of families with cavernoma. That is very interesting to see. It's possible to see mainly in women, and we must take it by it's possible to approach sometimes through the hydrocephalus. This is a type 3. This is the characteristic of the MRI. Normally, we have a chronic MRI with hemosiderin staining within and around the lesion. So it's different, completely different than another types of cavernous angioma. This is part of radiography in this kind of resection. I think what was the first described only near to the foramen of Monroe, Professor Schroeder, but it's completely different lesion and completely different approach. So it's very interesting in all of my life to see different cases and very interesting cases. We use normally the endoscope like assisted clipping. That is not so important because a lot of people do that. But sometimes they discover this kind of lesion. For example, in a street aggression in a patient that we have a very huge, after the trauma, a very huge lesion of the carotid internal artery near to the sphenoidal sinus, and develop a pseudoaneurysm, very huge pseudoaneurysm. And we propose, for example, to treat by endovascular. You see here this is a lesion. It's not possible to pass. The endovascular surgeon refused to do the procedure because they have the high risk to stenosis and the thrombosis of the artery. So we try to explore the endonasal approach because one of the possibilities is to explore inside of the endonasal and near, you see here in the MRI, which is the location of the lesion. Perhaps the endonasal approach, we try to do an exploration and then see what's possible or not to clip. The other thing is to close the carotid artery, but it was so young to close all of the carotid artery. So we prefer at the start discover the carotid artery near to the neck, and then to continue to explore by the endonasal approach. Another possibility is intracranial bypass, endovascular, internal carotid artery occlusion, and so on. But we decided to do this MRI you see here, which is a lesion. And it's very interesting with the NT surgeons to discover first the common carotid artery, internal carotid artery in the neck, in order to control the proximal bleeding. Also with the use of intraoperative monitoring, that is very important to try to do. And then we try to do the procedure. See here, with the monitoring of the intracranial. And this is the image that's very interesting, very nice, because you see here a huge mass covering with a lot of tissue that they put the NT surgeons also with inferior turbinate in order to protect, to try to avoid the bleeding. But we must to take in mind this kind of lesions try to rebleed or bleed in more than 50% with catastrophic results. Only not more a lot of patients survive after the bleeding. You see here, this is part of our dissection. To starting to explore what happened and try to discover. This is the part of the neck of the, you see here, this is the part of the neck. And then we try to put the second clip in order to reduce the aneurysm. You see here. And then sorry, I don't know why, because it's not possible to see the. Okay, you see here, and then we did the procedure with putting the third clip in order to block. So the result was very nice. We closed all of the aneurysm, and normally we use Gore-Tex in order to cover the surface, not to make a very huge inflammatory reaction, but it's possible to protect like a wrapping without a huge inflammatory reaction. So it's very, very important to do that. I think that I have problems with another video, but doesn't matter. The other thing is to use in spinal. In spine, it's very important to use the neuroendoscopy, sometimes the flexible one, because it's possible to discover and to treat spinal, intradural, and extradural lesions. You see here the history of the using of endoscopy in spine lesion a long time ago by Burman, for example. And then we discover mainly the Japanese authors, the fiber optic, and a lot of things that is possible to do. You see here the spinal neuroendoscopy is possible to see through the subarachnoidal space, perhaps inside of the syringomyelic cavity, inside of the cyst. And you see completely different images that you obtain. It depends of the area you're exploring. That is very important. So we must be trained about that. And it's possible to travel, perhaps for the start of the hiatus sacralis, near to the cranial basis. You see here part of the image of the syringomyelia, for example. You see hemorrhage in the wall. It's possible to dissect with a Fogarty, which separate and fenestrate all of the commissures that they are in between all of the septum near to the syringomyelic cavity, and it's possible to reduce the cavity. You see here? You see here in spinal cyst, for example, is another part, is another thing that is possible to travel near to the subarachnoidal space. And it's very important to make both fenestration in the upper part of the cyst and in the lower part of the cyst in order to try to reduce. And it's not necessary sometimes to leave a tube like in the syringomyelic cavity. It's not mandatory. Sometimes only with endoscope is nice to see the results. You see here, there are two completely different areas. From the left, you see the arachnoidal space in the spinal canal. You see a lot of roots, and it's possible to go through the subarachnoidal space. And the other one in the right is inside of the syringomyelic cavity. So we must to be adapted with both images. You see here also different areas. You see in the arachnoidal space, in an arachnoidal cyst, completely different and go inside of the syringomyelic cavity. This is the same thing. You must to be adapted that if you are inside of a arachnoidal cyst or you are in arachnoidal in syringomyelic cavity, you must to fenestrate the upper part and the lower part with a small hole with the endoscope, the thin endoscope, or the Fogarty catheter, or a small scissor, or a small forceps. That is very, very important to see, to have also to have the very nice results. The other thing is epiduroscopy. It's actually very common. That is possible to do via the hiatus sacralis with intraoperative RX. Normally, I use the 0.5 millimeter semi-flexible endoscope with the standard procedure. And normally, we're using fibrosis in all cases, despite the negative MRI. And then we can explore and discover a lot after the laminectomy, a lot of fibrosis, despite the MRI is quite normal. This is the position of the patient. You see the hiatus sacralis approach, and it's possible to see a lot of images near to the roots. It's possible to leave also catheters for the treatment at least 2 or 3 days after with corticoids, steroids, and normally a lot of anesthetic and a lot of things with the anesthesiologist. They are very specialized in pain. You see here very interesting images, normally in the approach of the epiduroscopy. A lot of arachnoidal area that is possible to free, to liberate, and perhaps after the explore, you see after the steroid treatment, you see completely free of adherences, all of the roots near to the spinal canal. So it's very important sometimes to use. This is our endoscope that we have a long time ago, and actually survived more than 23 years, and it's very, very important for us. The problem is the evidence of epiduroscopy against the pain or not is under discussion, but I think it's one of the possibility to treat, and it's one of the possibility that the young people try to take in mind and know how to do this procedure. Also, the syringomelia, you see here, the very nice image in order to put or not a catheter. You see here the treatment of syringomelia, and that's the results. They are very, very impressive. That is not depend of the results of the clinics. That is another thing. One thing is the improvement of the image of the patient, and the other thing is the improvement of the clinical symptoms. And this is one of the cases that I discovered last 2 years. Here in Uruguay, you have sometimes the hydatid cyst in a different part of the body. But this patient was operated once a long time ago, and actually it's a very, very bad condition with a lot of sphincter disturbances, with paraparesia and paraplegia. And we tried to discover what happened. We did an MRI and discovered a lot of very huge spinal hydatid cyst residue, and the approach through endoscopic approach. Also, you see here a lot of bone distracted really by the chronic inflammatory reaction. You see here, using endoscope, you see here a lot of near to the sacral bone and the coccyx bone, and near to the the lateral part of the spinal canal. And you see a lot of lesions of this, a lot of cysts around of the fibers and around of the roots. So we try to remove with the endoscope, and you see here a lot of roots near to the lesion, and we did the removal, and the patients unfortunately recovered, and they continue with medical treatment. That was very important to continue, not only the surgery. The other thing is the last, perhaps, is using the restorative neurosurgery with first national experience. They used with stem cells, with one a very, very famous hematologist here, that they did the implants and transplants for the hematological lymphoma, leukemia, and so on. And they proposed to treat several degenerative diseases, and we did the first stem cells implant. You see here part of the application of restorative neurosurgery and degenerative diseases of central nervous system, and vascular pathology and brain tumor also. What they use in LAS with a very severe illness. This is part of the cellular plasticity, and a lot of receptors, a lot of things to know. They are very, very difficult to know cytokines and a lot of things. So this is part of the concept and the basis of the It's necessary to know for a neurosurgeon. And we use in amyotrophic lateral sclerosis with a very, very difficult pathology. And we use in a very small, very minimal invasive procedure. We use it with neuroscopy and the spinal level, T11, T12, with general anesthesia. And normally we try to use semi-flexible 0 degrees endoscope. We put the stem cells near to the spinal cord and then in the CSF fluid and then in the blood. So we try to make our controls with the score, also with the neurologist. You see here the obtain of the cells. You see here like the gold color. It's very interesting. And in the left, you see in the posterior part of the spinal cord all of the stem cells. They put with the endoscope, and they coagulate around, and they start to migrate in the areas that they are damaged by the ALAs. It's very interesting to see this procedure. Also, we checked what happened 1 year after the procedure. You see all of the implants near to small niches inside of the spinal cord. And then you see here the epiduroscopy, small around very small hole of the 1 millimeter and no more in the dura mater, and then you see the posterior part of the spinal artery. We use also this kind of procedure was approved with the FDA, and also this is our casuistic. But the last procedure that we did is mainly in the spinal injury, traumatic spinal injury. The use was olfactory and sheathing cells near to the nose, with combined with the stem cells, also in traumatic spinal cord with very nice results. And normally we did the comparison with mortality rate with the treated group and the control group with the medical treatment. And normally we have a very nice results. This is our Kaplan-Meier curve that we compare in the last scientific paper. This is a stem cell group with we compare the Kaplan-Meier results. That's very interesting. This is our results. In more than 24 months, 5 patients died, because we must not to forget that the ALS is a terrible disease and actually it's not under solution. It's only one part perhaps for perhaps to extend the survive 6 months and no more. But it's very interesting. This is part of the combined of the olfactory sheathing cells. You see here mainly in spinal traumatic injury that we did in 11 patients with different kind of paraplegia and lesions. We had good recovery in 6 cases. We improved the ASIA score. Also partial recovery in 2 cases and no recovery in 3 cases. That is very interesting to see here. You see the implant. It's very important. This is a black point in the middle of the dorsal spine, and it's very interesting to check. Here is part of the pathology that we check and use normally in the sheathing cells. We're trying to check if we have or not a lot of olfactory and sheathing cells with a lot of possibility to develop neuroplasticity, cytokines, and it's our checking of the ASIA scores with sensory, motor arms, and motor legs. Another possibility was only patients, or 2 patients, one in Alzheimer and one in Parkinson. It is possible to do this kind of procedure with the consent of the family and the patients, and it's possible to do that with not so good results, but the endoscopy is also possible. We present these papers in several parts of every worldwide, mainly in Vienna, in Forum of MNT in Hamburg, in Germany, and a long time ago, remember this paper in the American Congress of Neurosurgery, and then it was very interesting. We received a lot of possibility to develop this, but we're trying to give this possibility to the young people. This was in one of the clinics in Chile, in Santa Maria. It was very interesting because they have a lot of research about that, mainly in Spain. You see here, for example, in Chile and normally in Spain, it's a very important persons are really interested in develop this field. This is part of our publication last 1 year or 2 years ago in 2020. with combine of factory ball stem cells and combining hematopoietic and raquimedullary trauma. It is part of our book. A long time ago, we start with the International Federation also. You see here part of this book because we mainly wrote about the spinal approach and mainly in this kind of approach with stem cells. This is part of the bibliography. This is a Professor De Bellis was was not a neurosurgeon. He was a hematologist, very famous here in Uruguay, and he promoted and encouraged me to do this kind of procedure. I remember him very well because he treated to me about Hodgkin lymphoma a long time ago, and he cured to me, and actually I remember with him very well. This is part of our activity in Spain, for example. We have a huge team. And I remember very well my visits and my formation in normally in formal times in Vienna. Actually, continue giving concerts there and also trying to visit also in Graz with Professor Wolfsberg. And for the list, the situation is normally a pianist, guitar, or a singer is normally practice normally 30 hours a week, performing 10 hours a week, and start at the age of 5. And then neurosurgeon, you hear a lot of very famous Vladimir Horowitz, very famous guitar player, Narciso Yepes and Teresa Berganza. My father, Waldemar Cordoba, was a very famous opera singer. But neurosurgeon, you have here practice sessions normally 0 or 4 hours. We are working every time, and we start at least at the age of 25. So if you compare a musician with a neurosurgeon, a musician is better because they have a lot of practice in her laboratory, practice the instrument, study music every time, and practice and playing every time. So we need much more practice in order to learn. You see here when I was young with Professor Schroeder in our courses here with a lot of residents from different countries. Here, Professor Bauer, one of the introductors of endoscopic procedure with GABA, and Professor Dieter Helwig from Germany. Normally, at the final, I will try to show these things because normally my surname Cordoba is a Spanish surname, and normally if you go to this city of Cordoba, you see this announcement in Spanish that they are talking about the connections between the different forces of the life, one part from the other of the world through vascular, like for example, a river or vascular stream that is possible to combine both possibilities to make for the human being much more easy to survive. Is mainly to try to expand or mainly in the possibilities to learn each other and not to fight each other. That is very important to see. Well, thank you very much. I have a lot of things to see to say about that, but I tried not to be so long. Perhaps for the next time, combine the music and neurosurgery, and that's another subject. Thank you very much for all. Thank you very much, Maria.
Thank you very, very much, sir, for this wonderful and elaborate and extremely interesting talk. We were all literally glued to your lecture and your wonderful cases and everything that you have shared and your own experience. Thank you very, very much, sir. And I think we are all excited to welcome you again to listen to your wonderful lecture of neurosurgery and music. I think it will be extremely interesting and it will be really informative. So thank you very much again, sir. And I think that I'm already inviting you. I'm trying to have this honor of inviting you again for another lecture. So again, thank you very, very much.
My pleasure, my pleasure. You see, somebody has some answer, some question I have answered is possible for the next time or now. I have enough time.
Thank you very, very much. So there is, so first of all, I want to also tell you that we also have the word Cordoba. We called it in Urdu and in Arabic, we call it Kartaba.
Yeah, perfect. Yeah, for sure.
Exactly.
An Arabic name, mainly an Arabic name. We have a lot of possibilities, but I think it's mainly an Arabic name. Alvaro also with Al is also sometimes an Arabic name.
Exactly, so it's an Arabic L. And I know someone, an aunt of mine who's also called Cordoba, and it's a very wonderful name that we really wish to use, and we have a lot of respect for this name because of the Cordoba Mosque is also very famous, and our national poet wrote a whole poem on the Cordoban Mosque on his visit, and he shared all these very remarkable artistry of the artisanal work of this beautiful mosque and the beautiful city. So again, thank
Exactly.
you. Thank you very much, sir. Sir, also, I'm so much intrigued to see all you have shared so many wonderful points, and I think you have left so much for everyone to think about and to know about. So again, thank you very much for this very stimulating talk, sir. Also, this the triple NE, the neuro navigation endoscopy, the triple NE is gaining a lot of interest in recent times, sir. But again, they say that obviously there's a issue of availability and obviously the issue of expertise. But some of the time they say that obviously neuro navigation may make some of those lesions which might not be neuroendoscopically operated otherwise, but they make it very much possible for neuroendoscopy to reach those lesions. So what, but again, they say that the right, probably the right patient selection is the key. So what do you think about the scope of of application of regular application of neuro navigation and neuroendoscopy, the triple NE? What do you think about the scope of this wonderful trips?
Sometimes you don't need. For example, if you are reaching by the anatomical landmarks, it's possible to reach your ventricles. The thing is, if you have it, okay, you can plan and you can see and you can plan the approach for the ETV and so on. But normally, if you have not, no problem. If you have perhaps an ultrasonography, it's possible to check with an open fontanelle. It's possible also. But also, normally you don't need, if you have, it's possible to do that with the anatomical landmarks. This is without no problems. If you have it, that's perfect. But the concept that it's not possible and it's forbidden, no, that is not true. This is only for the developed countries and so on, that they have a lot of machines. So it doesn't matter. Because I did a lot of ETV without problems. So it's not so easy, not so mandatory to do that.
Thank you very much, sir. There's also some recent interest in extra axial third ventriculostomy, and they say that it's very good that it does not have to go through the brain parenchyma. So, what do you really believe about this extra axial third ventriculostomy? Do you think that it's something that you would like to consider, or do you appreciate this approach?
No, normally I die, no, because it's the third ventriculostomy is possible to do that in the common approach. Intraventricular is possible also through the fenestration of lamina terminalis. That is the ancient procedure without a long time ago. I think it's not necessary. If you try to do in the proper way with an anatomical landmark exactly, and try not to go laterally, and it's a very simple procedure without a lot of problems. Also, when you reach the ventricle, this is a much more difficult thing. You must coagulate very carefully before to introduce the endoscope, and then with a cushion, I use the cushion trocar, and then I put the ventricle, and then I put the endoscope in order not to avoid the bleed. The thing is the bleed near to the choroidal plexus and near to the perforator of the third ventricle. But if you do the procedure without trying to travel around or to see a lot of things and to move laterally the endoscope, you have no problems. You don't need much more sophisticated machines.
Exactly. Thank you very much, sir. There's also this very controversial or yet very young very young introduction of the 3D endoscope, and they say that it's going to improve the visual spatial orientation. So what do you really believe about the 3D endoscopy superiority over the 2D endoscopy?
In order to be honest, 3D for me was very enthusiastic in general images. But when you discover perhaps it's possible to use in 3D models, actually it's a very nice devices, but it's not mandatory. you have a common endoscope because normally the very ancient endoscope are very nice images, are very nice optic quality. You don't need more. You don't need more. It's only to see, and 3D. If you remember, for example, in television, normally they abandon the companies. Normally they not reproduce more 3D television for the people normally because disappear for the market. So I'm not sure it's really the advantage to use continuously the 3D image. I think if you have a common approach in 2D is nice because another thing is we are thinking about that we have is not possibility to have the new machine is expensive, and this is the market problem. This is not scientific problem; it's a market problem. So we must take in mind separate those things.
Exactly, sir. So although I think the augmented reality sounds quite promising and sound interesting that you can actually augment the patient's own images over the operative field. It sounds very futuristic, very interesting, sir. Sometimes that we read about the augmented reality, it sounds a little more interesting to think that if a new technology is going, towards something new, if they are going to make innovations, it could be maybe the AR may be something good, but I believe 3D is also they have more disadvantages. Sir, there is also, when we think about microscopy combined with endoscopy, and those newly introduced exoscope versus exoscope and endoscopy combination. So what would you prefer? Would you like to have the exoscope combined with endoscope and have those two monitors alongside, or would you like to have the advantage of microscope combined with endoscope and having those better visualization and the depth perception and everything? What's your opinion?
Actually, it's the same thing in the market. It appears the endoscope, the exoscope, and you're trying to say that they are replacing the microscope and ergonomics and a lot of things. You are not sure if you're the propaganda for the business or really of the companies or really is a scientific basis. I am not sure. I think also with a common, a very sophisticated microscope, it's possible to transform in an exoscope. For example, the Kainevo and other models. But it's not so necessary. And I think that if you use a very nice microscope, is also with the endoscope, the exoscope is if you have it, okay, but it's not mandatory and it's not forbidden to operate neurosurgery without an endoscope. I not agree with that.
Thank you very much. So there are a couple of questions in the chat box as well. Sir, there's a question from Dr. Juan Miguel Elemen Iniguez. He wants to ask, thank you very much, sir. Congrats for your brilliant experiences. In ETV, thank you. In ETV failure, what is your policy for the cases?
Normally, I try to refenestrate or at least for explore, because sometimes it's closed with scare and it's possible to do, and the rate of failure is less than if you put a shunt. Normally, if I did it once, I try to do the twice, try to fenestrate, or at least to explore. If I see perhaps open, I try to put a chance. But normally, you obtain an image of a scar, it's partially closed, it's not in good function, and it's possible to redo the procedure. So the third time, it's possible to leave a catheter or a shunt.
Thank you very much, sir. So there's another question from Dr. Uday Bharti. He wants to ask, can we use a rigid scope for syrinx?
No, because it's very dangerous and it's very difficult. Perhaps semi-flexible, like this very thin, very small that I show you. But the thing is, the indication is for flexible. Actually, are very good flexible endoscope. They improve a lot the images, and I think without an exoscope and flexible endoscope, it's not possible to do it.
Thank you very much, sir, for your time. I think, okay, yes, sir, everyone is sending you a lot of wishes and a lot of appreciation, and we are all really thrilled to have you here with us today, sir. I think we have taken much of your time today.
Thank you so much. Take in mind for all of the audience and for you that I am the president, and I permanently to collaborate with you. If you need me, please write me, mail me, or so on. And then if you try to organize some courses, please tell me. I will give my support of the International Federation. And if you need also perhaps some part with you need an endoscope, for example, that normally in Latin America is possible. I will give my endoscope to you, and with like a presence. I am not interested in money and so on. So if some people need to expand and have not money to have an endoscope, I will give my endoscope to this person.
Sir, this is so huge, sir. Thank you very much. It's a huge honor. Like I said, I'm so short of words for to thank you, sir. It's a huge honor, and what you are sharing with us is what's really priceless. Sir, education and training is what's priceless, and that's what counts because it has the magnified impact, a logarithmic impact. Because as many people as you train are going to translate into a much more better patient care, and this is what really matters, especially in the developing parts of the world, because many of us are like feel like wasting our potentials, and it is because of you, teachers like you, that we are still trying to rekindle and to feel ignited to be our best selves. And we are still, I can frankly tell you that we are still in the field because of motivation from people like from the masters like you, and because you know that we have got some educational support from masters like you. And I think if without such a support, such an educational support, we must have long given up on our ambitions, and we were totally hopeless. So again, sir, it's a huge treasure and it's a huge honor for me and for everyone who is listening right now and who will be playing the recording on YouTube and neurosurgical.tv. And again, thank you very, very much, sir. I will certainly have the honor of collaborating with you. It will be such a huge dream come true for me. Again, thank you so much, sir. It's a real honor. Thanks a lot.
For me too. Thank you very much, Maria. I wish the best for you and all of the audience. I will stay in touch about that. Thank you so much.
Thank you very, very much, sir.
Bye-bye.
Bye-bye. Thank you, sir. Thank you, everyone, for attending this webinar. Your certificates will be emailed directly to you after the submission of the quiz. Kindly submit your quiz. It is a non-graded quiz just for your own practice and for the purpose of release of your certificate. It will be a personalized certificate that will be emailed directly to you automatically after submission of the quiz. It is a non-graded quiz, again, I'm telling you. So just don't have that type of a thing that you have to score a certain level to get that certificate. Just submit this quiz. It's a Google form. It's an MCQ based quiz, just 5 questions out there, and many of them have been discussed very nicely. And again, thank you very, very, very much again for joining us today. And I can see your wonderful messages. Thank you very much. Thank you very much, Dr. Ahmed Rizad, and thank you so much, sir. Thank you, Dr. Rene Gracias, por favor, for coming today. And Professor Gabriel, thank you very, very much for joining in. Professor Gabriel.
Yes.
Sir, welcome. Thank you very, very much for joining today.
Nice to see you. Just amazing experience of Dr. Cordoba. I think he was in Colombia one time, and he shows one picture training people from Colombia.
Oh, yes, exactly. So doing this webinar, it was so amazing and so good. So thank you so much for joining in. I remember you always organize amazing educational activities.
Yes, I would try to do this year also. So you are invited for that.
Oh, thank you. That will be a huge honor, sir. I will certainly be so happy to attend it. That's great. So thank you very, very much.
No, nice event and nice that you have that discipline to look for people that share the knowledge. Excellent. Congratulations, Maria. Congratulations.
Thank you very much. It means a lot to me. So your wishes means a lot to me, and your support in education is really, really appreciated by me and and by everyone. I believe, I totally believe, because it really means a lot to us. So again, thank you very, very much. So it's a pleasure, sir. I would certainly like to invite you to deliver a lecture on one of your own favorite topics, sir, for the new series. I will be really honored.
Okay, I will. Bye.
Bye. Thank you very much, sir. Okay, thank you very much, everyone. Please let me know if all of you have received the quiz link, and just submit it and receive your certificate. It's this much easy. Dr. Ahmed Pirzad, I guess I can see you also. Have a wonderful day. Okay, Zainab, here is it. Here's the link. Let me share it again. Assalamu alaikum, Dr. Ahmed Pirzad, and welcome to the meeting. Thanks for attending it. Thank you very much. So everyone, have you received this link? Dr. Nicholas, hi, thanks for joining the meeting. Dr. Nicholas. Okay, again, thank you very much, everyone, for joining the meeting. Thank you, Dr. Wasim. Thank you very much. Again, thank you very much for joining the meeting, and I hope to see you all again on 5th of February with Professor Martin Samis. And after that, there's another webinar on Epilepsy Day. So please join us for that as well. And obviously, please join us for GNC 2024 that will be on site in Peshawar on 24th and 25th of February, but will be also broadcasted on my own YouTube channel and on Zoom. And looking forward to welcome you all to all these 3 events next month in February. So again, thank you very much, and have a wonderful rest of the day.